And we're happy to introduce our next speakers, and that's Dr. Bourgeois and Dr. Bergmann from Hennigsdorf, Berlin, and they will present on precision medicine, innovations in diagnosis and therapy of sepsis. The floor is yours.
Thank you.
Thank you. Good afternoon. So today I and my colleague Deborah will present a little bit on diagnostic.
If you could, while you, yes.
Sorry.
Like that? Okay.
Yes.
We'll present a little bit on diagnostic and transitions towards precision medicine. So sepsis, as Professor Reinhardt just mentioned, is still the killer #1 in intensive care units. Even after the development and routine use of the procalcitonin, the PCT test, the number of sepsis deaths actually did not decrease. For example, in Germany, we have about 200 deaths a day. So what we are focused on is actually what are the mortality drivers in sepsis.
And to start with this, we would like to start first in order to have a look at the septic patient and what clinical picture do we see in these patients. So you may have a patient presenting in the ICU who has fever and chills, have an altered mental status, a fast respiratory response, and low blood pressure, all taken together, making the Quicksilver score. And you may diagnose your patient with sepsis. So over the course of sepsis, you start initiating antibiotic treatment and start monitoring your patient closely. So over the course of the patient may develop hemodynamic instability, which require vast amounts of vasopressors to stabilize your patient. And over the time, the patient may experience also a volume shift vascular leakage that presents as massive edema. Furthermore, the patient may show reduced diuresis, which may be signs of acute kidney injury, a reduced renal function, but may also be due to the fact just mentioned that you have vascular leakage. Over the time, the patient may also run into a sudden cardiodepression and, worst case, sudden death.
So when we look at this scenario, these are basics, or these are usually taken as signs of endothelial, loss of endothelial function, declining renal function, and among others, cell death. So based on extensive biobank research, our findings lead to we would like to highlight that basically loss of endothelial function, renal decline, and cell death are the major drivers of mortality in sepsis.
So first, in order to better understand what available diagnostics do we have today and what is routinely performed in a septic patient, we would like to emphasize that today we do have inflammation markers such as CRP, EL6, and also the procalcitonin to monitor a septic patient and guide antibiotic therapy. Now, to better understand what's the status of the patient with endothelial function, the low blood pressure and constant low blood pressure will give you a hint on where the patient is, as well as you can monitor and recommend to use lactate as a marker for hypoxia and hypoperfusion of organs. So for renal dysfunction, you can use the urea, you frequently use the serum creatinine and urine output. Now for cell death, subsequently there is nothing direct linked to that. You may also use here the lactate as a marker, an indirect marker of cell death, as cells may die due to hypoxia.
So basically, all these routinely used parameters are of course very helpful, but they're definitely unspecific. And when it comes to kidney function, for example, glomerular filtration rates of the kidneys is very hard to measure. And for years, this filtration rate has been estimated based on creatinine values. Creatinine, however, is basically contingent on many factors such as inflammation, which is very unfortunate in sepsis, and on top is actually delayed in comparison to actual kidney function. And what concerns cell death, this is usually not currently addressed in a routine manner in ICU.
Now, based on years of research and blood-based analysis, we try to better understand these causes of mortality and sepsis and try to really focus on these three causes and develop tools in order to better understand and monitor a patient. So when it comes to the loss of endothelial function, we identify a molecule which is called bioactive adrenomedulin, in short bioADM. This is a repair hormone that when it's inside a blood vessel actually stabilizes the endothelial function, whereas if it's outside the blood vessel acting on smooth muscle cells, it is causing vasodilation, which can subsequently lead into shock.
When we talk about declining renal function, the molecule we identified is proencaphalin, in short PENKID. So proencaphalin is a prohormone fragment of encaphalin, which in turn is a kidney-stimulating hormone. Encaphalin levels in the blood very well and consistently mirrors the actual glomerular filtration rate. So it's important to mention that we make no estimation, since the PENKID levels in the blood, they're very consistent with what is actually happening in the kidney. And finally, and very important factor is that PENKID levels are independent from inflammation, which is an essential point in sepsis.
To better understand cell deaths, we screen for quite some molecules in order to better understand what has actually happened and what is released up in uncontrolled cell deaths. And we found that there is an enzyme called the dipeptidyl peptidase 3, in short DPP3, which is a relatively new finding at the core of a recently discovered disease mechanism. So the DPP3 is a cardiodepressant factor. It is an enzyme that is usually located within the cell, but up in massive and uncontrolled cell death, it is released into the circulation, where it is incorporating its substrates such as angiotensin II and starts to degrade them.
Well, so once we have identified all these key molecules that we call biomarkers, we very thoroughly characterize them using more than 50,000 patients, more than 100 clinical studies, 30 indications, 20 countries, and more than 1,650 study centers.
And together with our collaboration partners, we did publish all these findings in peer-reviewed journals, more than 50 publications to date, and we're currently working with physicians in national and international hospitals in order to better understand how we can translate our research into a routine setting, and this is called the Lighthouse Project.
So now I will enter a little bit more in detail. So basically, after years of researching sepsis, I would like to summarize a little bit our findings on the mortality drivers in this field. So it's also important that what I'm gonna say next, you shouldn't understand as isolated pathways, but rather that these pathways can happen in parallel. So I will start with what is known, the trigger, which is the infection, which, for example, nowadays can be assessed by PCT or procalcitonin levels in the blood. As a normal reaction of our immune system, systemic inflammation takes place. So many patients during their hospital journey or their hospital stay develop complications and show symptoms of multi-organ failure. And depending on the severity of their state, they end up dying. So what I would like to focus now is what happens in between. What are the actual mortality drivers in sepsis? So an important aspect of sepsis is loss of endothelial function. Loss of endothelial function leads to shock and vascular leakage. This process can be easily identified by bioADM levels in blood. Once shock and vascular leakage happens, loss of organ perfusion takes place, which opens the door to multiple organ failure. Once the patients are in this state, they of course need treatment. And this brings me to the second important pathway. So when these patients are treated with the normal therapy, sepsis therapy, such as antibiotics and vasopressors, these therapies also harm the kidney to different extent. And we then observe declining renal function, and this can be very well seen by the PanKid levels in the blood. Once the kidneys start failing, this then consequently will lead to multiple organ failure. As a final pathway, I would like to highlight cell death. And cell death actually happens a lot, especially in the very critical states of sepsis and septic shock, mainly due to exacerbated immune response and of course hypoperfusion, so lack of oxygen. So basically when cells die in like a large amount, lots of enzymes are like put out of the cells and they end up in the blood. And one of these very important enzymes is DPP Tree, which is a fairly non-myocardial depressant factor. And DPP Tree release leads then to the loss of heart function. And once the heart starts failing, this will affect other organs and lead to the same pathway.
So again, we should keep in mind that all these pathways may happen in parallel, but for now we're going to focus on the endothelial function and the bioactive adrenomedulin. So bioADM is a marker for endothelial function, which allows us to early identify and monitor patients who experience a loss of endothelial function. So to understand why bioactive adrenomedulin plays such an important role in septic patients, we first of all should have a look at a healthy state. So what you see here is like the endothelial cells in light pink surrounded by smooth muscle cells in red. So you're actually looking at the blood vessel, and in a healthy individual, bioADM is produced in normal amounts. So having two functions, one stabilizing the endothelium, the bioADM acts on the endothelial cells and keeps them tight. So your patient is not presenting with any edema. So on the other hand, as the bioADM is such a small molecule, it can actually freely diffuse between the compartments and can also go outside the blood vessel where it's acting on smooth muscle cells. So here in a healthy individual, it is contributing to a normal blood pressure. Now going back to our septic patient, you can see that the light pink cells, so the endothelial cells, they form like holes within the endothelial barrier. So the body tries to repair this using bioADN and starts to produce more of that in order to repair the barrier function. Now, due to the systemic inflammation, it doesn't work completely, so the patient presents with massive edema. So due to the fact that this body is actually producing so much bioADM, it is also acting more on these smooth muscle cells, causing high vasodilation and then blood pressure drop and subsequent shock. So now we know that bioADM has these two functions, so one positive in order to restore barrier function and control barrier function, and on the other hand vasodilatory functions on the outside. So we're not only looking at our biomarkers as only biomarkers, but also as biotargets. So the company Adrenomed has developed an antibody that is actually targeting bioADM and is injected into the blood circulation, where it binds the bioADM and has the possibility to translocate the bioADM from outside, so the interstitium inside the blood circulation, and it keeps it active. So inside the blood vessel, bioADM can actually act on the endothelial cells and restore barrier function and reduce vasodilation. So this is something I would like to emphasize, is that Adrenomid just finished a phase 2 trial in septic shock patients, which Professor Mebasa is just gonna reveal first time results of this trial after our talk. Now, what you can do today already using bioADM as a diagnostic tool is, again, when we have a look at the septic patient and you see a blood pressure drop in these patients, how does the bioADM help you here? So bioADM blood concentrations rise prior to blood pressure drop, and that up to 2 days earlier. So it allows you to catch the first hour to treat the patient properly. Furthermore, bioADM is a very dynamic molecule, allowing the monitoring of the patient, and if the bioADM values does not go down, this identifies treatment non-responders, and if it goes down, you can say that your treatment is actually successful. So this allows you to timely consult other experts, such as the surgeon in example, in order to localize the infection, to guide vasopressor and fluid therapy, and in future to guide targeted therapy such as the adricizumab.
I would like now to focus on the DPP Tree pathway. So DPP Tree is a very important and very valuable biomarker that early identifies high-risk patients with risk of cardiac depression. So DPP Tree, actually, it's an enzyme that in the healthy state is inside the cell, and it's compartmentalized in the cell and therefore does not see its substrate in the bloodstream, such as angiotensin II. Angiotensin II is a very important peptide hormone that is responsible for hemodynamic stability and cardiac function. In a disease state such as sepsis, but also in burns, trauma, and surgeries where massive cell death occurs, DPP3 is released in the extracellular space and ends up in the blood. DPP3 will then uncontrollably digest angiotensin II, leading to cardiac depression and hemodynamic instability. So based on the fact that this enzyme is active in the blood, our hypothesis was that what happens if we block this enzyme, we will be able to restore angiotensin II levels and cardiac function, and the answer is yes. So we developed an antibody that when injected intravenously can block DPP3 in the bloodstream and normalize angiotensin II levels and consequently rescues cardiac function. So basically our experience with this biomarker by measuring many patients in the ICU is that DPP3 release is triggered by an injury to our body, an injury that causes massive cell death. Once this happens, DPP3 rises rapidly in the blood between 12 and 24 hours. These patients will then be in a situation that they have hemodynamic instability and cardiac depression, and at this time point, therapy escalation is started. So patients that respond well to this therapy will show DPP3 levels will reduce in the blood, but also very quickly in an interval of 12 to 24 hours. And low DPP3 concentrations in the blood are associated with positive outcome, normalized heart function. However, if these patients do not respond well to therapy and the DPP3 plasma levels remain high, this is highly associated with cardiac dysfunction, multiple organ failure, and short-term mortality. So in this setting, we could say that DPP3 is an excellent biomarker to assess patient severity in the ICU, definitely guide escalation therapy, as well as differential vasopressor and inotropic therapy, and lastly, guidance of innovative therapies. I also should mention that most of what is published on DPP3 is on cardiogenic shock, but we have very recently shown the importance of DPP3 in sepsis and also the really important role of the DPP3 blocking antibody in rescuing heart function in animal models.
So now looking at the third pathway, we're targeting the kidney function. I would like to give you some deeper insights in proenkephalin and as a biomarker to assess the true GFR. Again, it is not an estimation on the glomerular filtration rate, but actually mirroring what is going on in the kidney right now. But first, let's take a step back. So proenkephalin is a prohormone fragment that's actually produced by heart and kidney, and once in the circulation is splitted into the enkephalin, which is the active hormone stimulating kidney function, and the proenkephalin, a connecting peptide that's actually measurable. So the enkephalin stimulates kidney function, and what we measure is a stable fragment of this to indirectly know the enkephalin concentration. So again, when it comes to a course of aseptic patients, what we have today to monitor our kidney function is the serum creatinine, which may rise. So once this rises, you have to, per definition, you have the acute kidney injury. And over the course of the patient on ICU, this may go down. So how does the PanKid aids in diagnosis today? So as it's mirroring the true GFR, it is up to 2 days earlier than what we have as standard of care today. And being a very dynamic marker, it allows also the treatment and patient monitoring. If concentrations stay elevated, you know that the kidney function is not recovering, whereas the PanKid levels go down. This indicates improvement in renal function, also up to 2 days earlier than standard of care can do this today. So these early information will aid you to initiate the guidance of nephrotoxic drugs earlier, start nephroprotective strategies, and on top, actually PanKid is a biomarker that is still valid under dialysis, allowing start and stop decisions in these patients.
So this is like an add-on slide considering the critical corona crisis we're facing right now. So as has been widely reported so far, so the clinical spectrum of these COVID-19 patients varies from asymptomatic to very critical clinical situation, including acute respiratory failure and support in an intensive care unit. Critically ill patients, so corona critically ill patients, which accounts now to 5 to 8% of these patients, besides presenting with acute respiratory failure, these patients also present with sepsis and multiple organ failure. So here, it's a clear parallel to what we have been discussing today. And we would like to highlight that the pathways we talked about are not only applicable to patients that undergo sepsis, but rather to every critical patient that we see in the ICU.
And not only following the call of the World Health Organization, we've been initiating and working together with clinicians in order to introduce our knowledge into clinical practice. And there we partner with national and international hospitals. We do routine implementations using our whole blood rapid point of care test in order to really learn from physicians what can we do differently using our biomarkers, and emphasize the publication of case reports and peer-reviewed data. So with this, we would really like to work closely together with clinicians in order to improve standard of care in sepsis and beyond in critical care, such as in the COVID-19 patients.
So as our last slide, I would like to leave you with a summary of our pathways that we identified as mortality drivers in sepsis, identifying our biomarkers by IDM, DPP Tree, and PanKid, but also the drugs that are underway. For example, adjunctive that is a potentiating antibody targeting bioadrenomedulin, and protsisumab, which is an inhibiting antibody targeting DPP Tree. The next talk will focus on the endothelial pathway, and will specifically focus on adjunctive. So thank you for your attention.
Thank you very much for your presentation. I would start the discussion with the first question. You showed very nice schematics how you think the biomarkers could be used to track the course of the disease. What is the actual data for the value of these biomarkers? For example, for bioactive adrenomedulin, how well does it correlate with vascular permeability as measured by plethysmography as sort of probably the key gold standard for permeability in the clinic?
So basically what I can offer as an answer here, we have extensively investigated these biomarkers in several clinical studies. Most of them were, of course, retrospective studies, so it was not possible for us to, for example, use certain techniques where we didn't have any data to analyze on. However, bioADM has a clear added value on top of lactate, for example, that is recommended, and it highly correlates with congestion, with vascular leakage in sepsis, and this has been widely published in the literature.
But that's what I was asking. How is vascular leakage measured in these studies?
So we know from the concept, for example, we did cell experiments. So we had endothelial cells plated, and they were destroyed, and then we added on top bioactive adrenomedulin, and we saw that this is actually reformatting the endothelial cells and stabilizing the endothelial function.
I don't doubt about that, yeah. I mean, that's sort of well established in the field, but it's still a different thing to show that in a clinical situation it actually works as a biomarker for a certain disease process or for a certain pathomechanism, which I think is probably will still require prospective trials using specific technologies to address this pathomechanism. But I think it's an interesting step forward, yeah, to look at that.
So we have several questions from the audience, and I would like to repeat one or two. One is DPP3 also elevated in patients with chronic heart failure? Do you know anything about that?
Actually not. So DPP3 is not elevated in patients with chronic disease, at least in the wide spectrum chronic disease we have measured so far. We did not see DPP3 playing any role or being able to be associated with mortality or poor outcomes. DPP3 is more a biomarker that is related to disease severity, to critical situations in the emergency department and intensive care units.
Okay, and thank you. And the next one would be, can any hospital join the so-called Lighthouse Project, and how can one participate to these projects?
Well, so in principle, yes. So we do like to work with clinics who would like to work with us in order to better understand what's the clinical value and how they can treat patients differently. So yes, so please feel free to contact us, and we will see how we can work together on that.
And another one is on the question, how often shall one measure the biomarkers to get the most information? So what about the dynamics of these biomarkers?
Okay, so most of these all these biomarkers represented are highly dynamic. So they can be well used to monitor how the patient progresses upon treatment, for example. And the most added value we see, for example, for DPP3 is measuring DPP3 at admission, and 24 hours give a very good indication if the patient is moving the right or wrong direction. But for example, measuring bioADM is also very important when you're making a decision about vasopressor doses or vasopressor need in patients, and this can be mirrored by the bioADM levels.
Thank you very much. I think for the sake of time, we have to move on.